Hello everyone, I'm Mitra Asadi, Fellow in Endocrinology Department in UIHC. Thank you very much for completing the survey. I'm going to briefly talk about metabolic dysfunction associated steatotic liver disease or MASLD. So MASLD is a new terminology replacing non-alcoholic fatty liver disease. It happened in 2023 after several hepatology organizations decided to call the disease what it is, not what it's not, and to remove the stigma of non-alcoholic and fatty from the disease name. Spectrum of disease includes steatosis, affecting 5% or more of hepatocytes, which can result in steatohepatitis or MASH, again, which may or may not have associated fibrosis or eventually cirrhosis or hepatocellular carcinoma. We have to exclude other etiologies of chronic liver disease like high alcohol intake, hepatitis, viral hepatitis, HIV, or medications like steroids before making the diagnosis. So steatotic liver disease is an umbrella term. It contains metabolic dysfunction associated steatotic liver disease or a combination of metabolic disorder and alcohol use disorder, steatotic liver disease, when patients have metabolic dysfunction, but at the same time are drinking more than recommended alcohol, like more than 140 grams per week for women or more than 210 grams per week for men. Steatotic liver disease can be just because of alcohol use if there's no metabolic dysfunction present, or because of drugs or cryptogenic or genetic diseases. So when we say metabolic dysfunction associated, we mean that patients should meet at least one out of criteria for metabolic dysfunction, like elevated BMI or waist circumference or elevated blood glucose or diagnosis of diabetes, type 2 diabetes, or if they are getting any treatment for type 2 diabetes, elevated blood pressure, or if they are getting any antihypertensive medication, elevated plasma triglyceride, or low plasma HDL, or if they are receiving any lipid-lowering treatment. Why it is important? Because of the epidemiology. The global prevalence is 30% and US prevalence is 33% and it's rising. It's rapidly becoming the top indication for liver transplant among those who are listed for hepatocellular carcinoma and becoming the most prevalent steatotic liver disease. It has higher prevalence in males compared with females, and it is associated with increased risk of cardiovascular, kidney, and liver morbidities and mortalities. And it is associated with increased risk of non-liver cancers like colorectal cancer. The association with type 2 diabetes is important and significant. MASLD affects more than 70% of patients with type 2 diabetes in the US, and among those with type 2 diabetes and MASLD, more than half develop steatohepatitis, and 12 to 20% have at-risk MASH with clinically significant steatosis. Patients with type 1 diabetes can also get affected. The overall prevalence is 20% and is primarily driven by obesity. In US, 67% of individuals with overweight or obesity have MASLD. So we can see the close relationship between MASLD and obesity or overweight and type 2 diabetes. The main thing in pathophysiology is increased insulin resistance, which causes lipolysis in adipose and muscle tissues, and then free fatty acids travel to the liver, and they cause fat accumulation and lipogenesis. We're going to have hepatic lipotoxicity, resulting in oxidative stress, inflammation, and fibrosis. Genetic also plays a role. Genetic variants like PNPLA3, IFNL4, TM6SF2 increase the risk for MASLD. The majority of patients are asymptomatic. Clinical symptoms include fatigue and mild right upper abdominal discomfort. Patients may have mild or moderate elevations in AST and ALT, although normal liver enzyme levels does not exclude MASLD. Imaging modalities like FibroScan and magnetic resonance elastography are helpful in screening and diagnosis. So now that we know the prevalence is high, how do we screen patients? We have to identify patients with high risk for MASLD, like with type 2 diabetes, prediabetes, or obesity with cardiovascular risk factor. This algorithm is recommended by American Diabetes Association. So we have to calculate FIB-4 score, which in the next slide, I will say based on what criteria it's calculated. If it's 1.3 or above 1.3, but less than 2.67, it means that patient needs to undergo fibroscan, which is an imaging modality, and it gives us liver stiffness measurement. If the number is 8 kilopascal or above 8 kilopascal, it means that patient is at high risk of cirrhosis, so we have to send them to a hepatologist for further workup. But if liver stiffness measurement is less than 8, it means that patients can be managed by primary care or endocrinologist. We have to optimize lifestyle and treat their comorbidities and repeat FIB-4 score after a year or two. If FIB-4 score is already above 2.67, it means that patient is at high risk of cirrhosis, so we don't need to do fibroscan, we just have to refer them to hepatologist. If FIB-4 score is less than 1.3, it means that patient doesn't have high risk for cirrhosis, there's lower risk, so we can again manage them and optimize their care for type 2 diabetes, obesity, and encourage healthy lifestyle, and repeat FIB-4 score after a year or two. So in UIHC, calculating FIB-4 score is easy because we have to just use a dot phrase, which is created by hepatology and endocrinology department. So FIB-4 score is calculated based on AST, ALT, patient's age, and platelets. And again, it gives us a FIB-4 score. If less than 1.3, then patient is at low risk of cirrhosis. So we know that we just have to repeat it after a year or two, in addition to managing their comorbidities. If it's between 1.3 to 2.67, it's indeterminate. So we have to perform fibroscan. And if the number is already above 2.67, we have to refer them to a pathologist right away. How we do manage them? So lifestyle modification is cornerstone of therapy, meaning healthy diet and exercise. Mediterranean diet is a good choice for healthy diet. Weight loss, 3 to 10%, was shown to reduce steatosis and help in fibrosis regression. Again, we have to manage existing comorbidities like type 2 diabetes, dyslipidemia, hypertension. We have to strongly encourage patients to avoid alcohol and smoking, and bariatric surgery can be considered for some patients who need weight reduction. Pharmacologic treatments. Semaglutide 2.4 milligram weekly is approved by FDA, as well as resmetirom, which is selective thyroid receptor agonist. And American Diabetes Association recommends pioglitazone and even recommends combination therapy with pioglitazone and GLP-1 receptor agonist. So, take-home points. MASLD is the most common chronic liver disease. It needs multidisciplinary management of cardiometabolic risk factors. And early identification of high-risk patient is key because then we can prevent the progression of disease into fibrosis or cirrhosis. Lifestyle modification like healthy diet and exercise plays an important role in managing these patients. And we can initiate FDA-approved therapies if indicated, like semaglutide or resmetirom. And we have to refer some patients to bariatric surgery if they need surgery for weight reduction. These are my references and guidelines, and thank you very much for your attention.